Okay, let's talk about this cool case of an ovarian torsion from a dermoid cyst. This was a 22-year-old female who had been pregnant once and had one living child, presenting with sudden onset of severe right-sided flank pain to the emergency department. It started 4 hours previously, and she characterized it as sharp and constant and radiated to her lower abdomen and was associated with nausea vomiting. She did not have any fever or chills. She was otherwise urinating normally and had no constipation or diarrhea. She states she's currently on her menstrual cycle, but this is a different pain. She did not have any injuries or trauma, no history of kidney stones, and no surgical history. She does not smoke or drink. On exam, her heart rate is 97, right? Borderline elevated. Her blood pressure, temperature, respiratory rate, and oxygen saturation are all normal. She looks well but uncomfortable. Her HEENT, cardiovascular, and respiratory exam are normal. Her abdomen is soft, non tender, non distended, without any CVA tenderness. Pelvic exam had no discharge or bleeding, normal uterus, no cervical motion tenderness, and a right adnexal mass was palpable on bimanual exam. In the ED, labs and IV were started. She got morphine, ketorolac, and ondansetron. She was not pregnant. Her urinalysis was basically normal. She had some hematuria. Her CBC and CMP were normal, and a CT ab and pelvis was ordered. Let's talk about a dermoid cyst. This is a benign growth that accounts for about 15% of ovarian tumors, often presents with pain and pressure, and torsion is the most common complication of this cyst. It is very rarely malignant. The best imaging modality to initially evaluate it is a CT scan. Torsion, ovarian torsion, is a gynecological emergency requiring a quick diagnosis and surgical intervention and can occur anywhere along the adnexal structures, including the ovary and fallopian tube. Risk factors for developing a torsion include an adnexal mass, as the case with our patient, being pregnant, ovulating, and then a history of prior pelvic surgery. The most common risk factor is a dermoid cyst, which is seen in about a third of cases. And almost every ovarian torsion involves some type of mass, almost 100% you can see there. And it represents about 2 to 3% of gynecological emergent surgical cases. On exam and history, patients will report sudden onset of colicky lower abdominal pain, often radiating to the groin and kind of seems like renal colic, like a kidney stone or kidney infection. However, less than half of patients present classically. Half of patients prevent previous episodes of similar pain, so maybe they were torsing and detorsing. 70% have nausea and vomiting. Fever is rarely present, which makes sense. This is not really an infectious problem. Palpable mass in about half of cases, and a third of women have no tenderness. So clinical diagnosis here very tricky. Evaluation is to rule out pregnancy, look at urine for evidence of infection or kidney stone. Ultrasound is typically considered the initial imaging of choice. 93% of cases have abnormal ultrasound. Note that is not 100%. And findings include enlargement, prominent follicles, infarction, and abnormal color Doppler. And if we look at the right side of the screen here, this is an ultrasound. You see the left ovary normal in appearance with color Doppler on showing flow, vascular flow to the ovary. And then if we go to the right ovary, the pathologic ovary, we see it's dramatically larger. It's enlarged, it's edematous. And then with the same color Doppler on, you don't see any flow within the ovary, right? You can see the ovarian artery here and our vascular structures here, but you do not see any within the ovary itself, which implies torsion. CT is less sensitive, but it looks at the other structures a little bit better, so you can evaluate the pelvic mass or evaluate for kidney stones or whatever else you might consider in your particular patient. Treatment involves excision of the dermoid cyst and surgical detorsion of the ovary, if it's viable at least, preferably laparoscopically so they don't get big scars. Here's a CT scan. Here's the left ovary right here, okay, and then the right ovary much more heterogeneous and enlarged. It's hard because this is a 3D image and we're taking one slide, but if you were to scroll up and down in this axial plane, you would see this is a very enlarged, heterogeneous appearing ovary. And so the case with our patient, she was diagnosed with a nearly 7x5 heterogeneous mass with soft tissue, calcium, and fat components in the right para midline of the anterior pelvis. When she went to the OR, they diagnosed her with an adnexal torsion and a 6 centimeter dermoid cyst, which was taken out. The ovary was viable. The patient had a good outcome. And then the pathology of that cyst was a mature cystic teratoma. So 3 key points about ovarian torsion. The first is characterized by abnormal rotation of the ovary, resulting in ischemia, and if not treated correctly, infarction and necrosis. Patients typically present with right-sided abdominal pain, although remember, less than half of patients present typically, and diagnosis is confirmed with ultrasound or CT, and treatment is surgical detorsion and excision of any masses that may be present.